Bismillah wa salatu ala Sayyidina Muhammad. First, I'd like to thank the organizing committee to invite me to have this lecture. And thank you, Dr. Osama, for this introduction. In brief, today we will talk about a direct oral anticoagulant. It is a group of new drugs that consider as a big category, which is anticoagulant drugs. In briefing, this group has a similar and better efficiency and safety and better safety in comparing to old or classical anticoagulant drug, which is warfarin. They are easy to use in outpatient setting, and they have a higher standard in comparing to warfarin and low molecular weight heparin. The direct oral anticoagulant they offer in a simple dose. They have short half-life and wide therapeutic window. And they have a superior feature, which is no drug interaction. This is in briefing. This group is considered as either direct thrombin inhibitor or factor 10 inhibitor. The example of those group is dabigatran, which is the famous or the first direct oral anticoagulant that has been appeared. And we have also another drugs like rivaroxaban and apixaban and edoxaban. After almost a decade of using of this group, there is a big question about the need of testing of those drugs in certain situation, and this become a focus of debate. In this lecture, we will try to understand this question or debate, and also to highlight some potential way of testing of those drugs. We have a question. We try to answer it here. When to assay direct oral anticoagulant level, which test is possible to be used, and how to analyze the result coming from those tests, and also the impact of using of direct oral anticoagulant in routine coagulation lab. I will start by background about anticoagulant in general, then we will go to when and why to assess, then we'll go to test the what tests used to determine the presence of those anticoagulant and impact of those anticoagulant in coagulation function, and also the potential strategy to overcome this obstacle of using of those drugs. Actually, anticoagulant is a group of drugs that targeting to overcome the abnormality of normal hemostasis. The normal hemostasis or coagulation is a process has three phases. The first phase, which is vasoconstriction, this is a natural response to normal injury, starting by vasoconstriction, then platelet aggregation, and the last phase, which is clot formation, which is a very complex phase, including activation of coagulation cascade, which extrinsic or intrinsic pathway. The new drugs, they targeting the last phase, which is clot formation. Here, this is the coagulation cascade or coagulation process. It is actually very complex process, but they simplify it in this way to understand it and also to design lab test and therapeutic approach. You know, we have intrinsic pathway and extrinsic pathway include several factors. Our interest here is factor 10, which will be targeted by a group of new drugs, and also the thrombin. As usual, abnormality, as you know, the abnormality of coagulation can lead to forming of thrombus, which is a big group of disease. This is the form of thrombosis. It is several form present in several parts of the body. This is the form of cross-section for clot that occlude vasculature and leading to consequence of hypoperfusion. Historically, the anticoagulation or anticoagulant drug, they start by using warfarin. This was started more than 60 years from today. The idea of anticoagulation is starting by discovering of unexplained cow death in United States and Canada. Those cow, they has uncontrolled internal bleeding, unexplained. That was in 1920. Then 1949, chemists, the research chemists, they try to explain why those cow has died and explain why this internal bleeding. They discover there is unknown substances which was dimecrol from sweet called hay. Later, this substances has been extracted and used for rat poisoning. That was by Wisconsin Alumni of Research Foundation. The name of warfarin is coming. WARF as abbreviation of this foundation. They continue using as a rat killer. That was in the United States.
So we keep poisoning our patients.
Yes. And we try to to be away from this poison. In 1955, in my clinic, they start using that substances or warfarin for Eisenhower to treat him from heart attack. We continue to use warfarin for many years, more than 60 years. And annually about 30 million prescriptions written annually in the United States alone. And also it was as well as it is increasing still now. Warfarin is very cheap drug. It is costing about $4 monthly supply from the pharmacy. Actually, it is cheap, but they have a very significant problem that related to narrow therapeutic window. You can see actually the INR level is between 2 and 3, so that the physician try to adjust this level to reach between 2 or 3 or 2.5 to 3.5. We don't need to increase the level of INR or decrease it, because we are between hemorrhage complication or thromboembolism complication. As you know, warfarin is a big issue in hospital. They usually they have warfarin anticoagulant clinic just to focus about the complication and adjustment of warfarin dose, so that the patient need to have a frequent follow-up in the hospitals, and also they follow a strict warfarin diet and also a strict warfarin time. Actually, the problem is not just that. Many complications happen by using of warfarin. About 17.3 of emergency department visit, it is related to adverse drug event in elderly adult in United States. And also 19% of this complications related to unintentional overdose. So that it is it's a very risky drug. In 2010, new drug is coming to the clinical practice and approved by FDA. And at that time, around 11.5 million prescription at that year. The superiority of this drug, because it has no drug and drug interaction. It's not need a special diet to overcome the complication of using of this drug. And also there is a limited interaction to other drug. This drug is dabigatran, or they call it Paradoxa. It's actually directing to, they have direct effect in thrombin, direct inhibitory effect in thrombin, so that it is a directed therapy. And other drug has been used, also is introduced to be used, like rivaroxaban, apixaban, and edoxaban. They have the same feature of dabigatran in general, and not require routine anticoagulant monitoring, and no dose adjustment is necessary, and this is in usual condition. Do we need to assess this drug in certain situation? Those drug need, they have a kind of clinical complication like bleeding. This is related to overdose, and sometimes is lead to spontaneous bleeding or internal bleeding and injury, or sometimes the need for assessment of the level in urgent surgery. So that the need of assessment of those drugs is starting by this clinical situation. And also in patient with renal failure or liver failure, they need to know exactly the level of those drugs. And also some certain situation like using of antidote to overcome the toxicity of those drugs, we need to assess the level of direct oral anticoagulant. Actually, the routine, the available coagulation test is not that sensitive like INR. INR is not considered as a sensitive or useful way to assess the effect of those drugs. What test has a potential to be used for assessing of direct oral anticoagulant? In dabigatran, there is this drug can the APTT can be used. The normal APTT exclude above the therapeutic level of dabigatran, and doesn't exclude the presence of dabigatran on the therapeutic range. So that only is present in above the therapeutic range. Thrombin test TT, it is normal in the presence of dabigatran. Diluted thrombin test has estimate relation to clinical in clinical context. Carine test is base plasma estimate the relation with clinical context. This is the relation between the diluted thrombin time and the dabigatran concentration, so that the presence of dabigatran can be correlated to direct thrombin time test. Also, the carine test has a strong relation between the level of dabigatran and the result of a carine test. Rivaroxaban, the level of PT is not reflecting the level of rivaroxaban in normal levels. We can use a chromogenic anti-10 assay for rivaroxaban, apixaban, and edoxaban. The golden way of assessment of all this direct anticoagulant is mass spectrometer, but unfortunately is not present in the clinical lab. This is used for research purpose and not available in an emergency situation. Normal DRVV result can exclude the presence of DOAC concentration of more than 50 nanogram. This is the mass spectrometer, which is usually which considered as a golden standard for assessment of direct oral anticoagulant. Actually, the using of chromogenic anti-10 assay is not currently available in all hospitals. It's need a collaboration. Anti-10A chromogenic using specific apixaban, edoxaban, and rivaroxaban collaborator are able to measure wide range of plasma concentration, covering the expected level after therapeutic dose, with the result expressing in nanogram per ml. For apixaban, depend on the reagent. PT may be normal in the presence of therapeutic level, which is around 200 nanogram concentration. Therefore, PT is not recommended. For estimating plasma drug concentration, apixaban, or assessing the relative intensity of anticoagulant on therapeutic dose. Now we can go to see the effect of oral anticoagulant in a group of coagulation factor that use daily. This very important to understand it, because this should aware the false positive and false negative related to the presence or the use of direct oral anticoagulant, and that can lead to diagnostic error. If we look to PT, we can see the result of using the dabigatran, which lead to low level of PT, rivaroxaban also, and apixaban, edoxaban. All this will lead to decrease PT. APTT also is affected by presence of all these anticoagulant. Lupus anticoagulant will be affected by increase of lupus anticoagulant in case of dabigatran, rivaroxaban, and apixaban may be normal or increase. And edoxaban will increase the level of lupus anticoagulant, so that this will interfere the result of screening for lupus anticoagulant. Also, activated protein C can affected by presence of dabigatran, rivaroxaban, apixaban, and edoxaban. Protein C activity may be normal or increase in relation to dabigatran, rivaroxaban, apixaban, and edoxaban. So that also the antithrombin activity can affected by presence of direct oral anticoagulant. This understand is very important because it can lead to diagnostic error in case of using that drug and screening for coagulation test. To overcome, the clinician must inform the laboratory of the using those drug, and the time of the dose related to a blood sample, so that the notification of the lab of using of those drug is very important. Now some company are currently developing a strategy to make those tests is insensitive to presence of direct oral anticoagulant, or to remove the direct oral anticoagulant from blood sample before the testing. This is the strategy they try to overcome the effect of direct oral anticoagulant in laboratory coagulation test. In conclusion, knowledge related to direct oral coagulant is emerging, and determination of those drug is now visible in certain clinical cases, like emergency surgery or drug overdose. There is a need for optimal balance between avoiding bleeding and preventing thrombosis. There is no consensus therapeutic range for those drugs. And also there is little urgency to make this test widely available for routine use outside the acute setting. There is very important to understand there is impact in hemostasis test, and this leading to false positive of those tests. And there is a need for a prospective clinical trial for validation and collaboration of those tests. This is my reference, and thank you.